This is our final voiceover PowerPoint, and it's a very brief discussion of end of life as related to complex care. So I know you've had information on end of life, and I'm not going to give a lot of detail on some of the slides. When we do this face-to-face, we have a nice little discussion, but most of this is for you to think about. But this particular part of end of life is related to when to give you some information about what you'll see when people discontinue codes and what you'll see when patients when they're actually passing away. So let's take a quick look at that. Here's your objectives, and the final point is just for you to think about. Think about your ethical practice and your leadership skills related to end-of-life issues and how you're going to do this and assist your patients moving forward. So for end-of-life care, we've had some issues and concepts you've already discussed. At this point, you've talked about the advanced directives, we've talked about living wills and healthcare power of attorney regarding who is going to help direct care for your patient when they can no longer help themselves or direct it themselves. So with end-of-life care, we talk about withholding versus withdrawing treatment. And withholding is probably a little more acceptable for most nurses rather than withdrawing. Withdrawing is an act of taking away something that's assisting them to stay alive. And it feels just, I think most nurses feel a little more comfortable with withdrawing treatment rather than not starting or withholding treatment, especially if the patient is pre-terminal or has clearly stated their wishes to not be kept alive. You're clear about the do not resuscitate orders. Are different levels. These are LETs. It would be where the individual identifies they don't want to be electrically defibrillated, that maybe they do want you to try chemicals to improve their heart rhythm, or they do or they do not want to be placed on a ventilator. I think you may have seen some of this in your own practice or in previous clinicals, but sometimes there are barriers to dying, and it can be disagreement of the healthcare providers where you have one or two specialists who are comfortable with letting the patient continue to make attempts to survive, and others that are indicating it is not practical and not going to happen. So those disagreements are best not played out in front of the family. But if they can have a family meeting to sit down and have the different physicians go over the pluses and minuses with continuing with extraordinary measures, then I think that's always very helpful for everyone to hear the same message. And then sometimes there's disagreement with family members where multiple members are fine with care being discontinued and one or two don't want that, and that's a good one for the provider to help kind of reduce or work with the disagreements. So if the decision is made that no more efforts will be made to keep the individual alive, then frequently the patient is placed on hospice or placed on some form of comfort measure as they prepare to pass. So you can see there's different levels of comfort care, and think about what you're comfortable with. You know, certainly we don't want our patient to be in pain, but we also know that there's certain pain medications that might hasten their demise by reducing their respiratory effort. So we want them to be as comfortable as possible and pain-free as possible, but knowing that this might interfere with breathing. So we, just watch that you're not over-medicating the patient, and the family is aware of that. Nausea can be very uncomfortable. Fever can be very uncomfortable. The appearance of a new infection, though, is a very interesting thought. So if a patient is made a do not resuscitate and is placed on comfort measures, do you treat a new infection? And a lot of people are like, well, of course you would. That's doesn't seem right to not treat a urinary tract infection or even a pneumonia. But what is the purpose of treating the patient? Usually treating an infection is for them to improve and get back to their usual state of being. If they do not resuscitate, there might be times when the patient is not treated for infection because the end point would be, again, just kind of resetting the clock to when is this terminal patient going to pass away. So think about how you feel about it. A lot of people feel very strongly that the infection should be treated. So think about your thinking and your feeling about that if a decision is made to not treat an infection. Edema can be uncomfortable and also can be have the patient look sicker to their family, or that it's not looking like them anymore. So they might treat edema to relieve like fluid on the patient. And then delirium, that's very distressing for the patient if they're no longer oriented to who's with them and what's going on. So sometimes patients will be medicated so they're not so agitated, but we want to make sure if they are able to talk with their family members or participate a little bit, that's helpful. Usually toward the end, they're not able to chat with their family or be interactive. As they pass away, we always encourage patients to be, families to be there with their family, to hold their hands, to talk with them, but they might not be able to respond back. As far as preparing for a patient's death, if the family needs to meet with all the providers, that can be very helpful. I've had students have said that when they had a family member and they had a family meeting, it was actually quite distressing to kind of hear the words and be in that situation. So just be aware from the family standpoint that this is not a meeting they're looking forward to. Sometimes the patient will need to be removed from support, including a ventilator, and it might be there's an out-of-town family member coming in and they don't want the family to pass away until that member's been there, and as long as it's reasonable, they will leave them on the ventilator. Again, pain medications can help there, so they're not being uncomfortable. It helps with, but a lot of the pain medications will sedate them as well. If it is appropriate, the provider will talk about organ donation, and probably before this time they've kind of prepared for that. And then family care. I know a lot of the hospitals, when families can again be with their family members as they pass away, they might even have a little service where someone comes around with coffee and tea, and so the family doesn't have to leave the room and hope that the patient doesn't pass away. So I know right now families cannot always be with their members as they pass away, so when this is reinstituted, this will be a help. Right now people are getting family members on FaceTime and iPads and doing some way so they can connect with the family. If you've not seen a patient pass away, there are some physiologic changes that happen. Now remember we talked about the golden hour in trauma? This is the physiologic changes are called the silver hour as the person prepares to pass. There's certain cardiovascular changes. The blood pressure gets lower, and therefore the hands and the feet get cooler and might even get a little mottled. There's going to be heart monitor changes. I'll show you some of those. You can see the skin color changes, pallor, gray, grayish blue, and that sometimes is scary to the patient or the families. You have to let them know what's going on. Their respiration patterns, they might have the chain Stokes where they, take some deep breaths and then stop. And I've had patients go, "Is that it? Is he done?" I'm like, "No, let's just wait." Sometimes this breathing pattern starts up again. So sometimes they get very gaspy and loud, which is scary. They might have increased secretions. You might have to suction them a little bit to make them comfortable. And then neurologic alert to comatose. More likely they're going to be foggy to comatose. If they're awake, they might be hallucinating. They might see people who've passed before them. They think that people can hear. There's been patients that have been critically ill, and they can tell you who is talking in their room, and I recognize your voice. So hearing is thought to remain the longest. So be careful what you say, but encourage the family, even if they're over a phone, to talk with their family members. If you're in a situation where CPR is being performed, it's like, what are they looking for to discontinue CPR? And it's typically there are a couple rhythms that can show up. VTAC and VFib are two of them. That doesn't mean if they show up, CPR is stopped. That's usually an indication for CPR. Even agonal rhythms, they'll continue CPR for a while until they feel that there's so much physiologic derangement. The person has been under CPR conditions for so long that they are not salvageable. So I believe the next one or two slides are dysrhythmias. So let's look at those. Let's look at those soon. There are some specific guidelines. The National Clearinghouse has targeted severely injured trauma patients for guidelines, and even any patient for CPR. They consider, is there survival without major organ dysfunction, like MODS? Is there risk for major organ dysfunction or major organ death? And overall, has there been enough physiologic derangement that the person is not ultimately going to be survivable? If you are interested in this, the American Association of Colleges of Nursing has a consortium where they allow people to get certification in end-of-life care. So if you are interested in it, this is the way to go. Even if you don't want certification but want more information, if your unit is having a lot of concerns with this, this is very helpful. Here are our EKG rhythms. So the first rhythm is kind of an agonal rhythm, meaning activity is not supporting cardiac output or life. And when this happens, you'll kind of see this you can see like kind of the end of a real sloppy ventricular fibrillation. It's not very fast. Then it slows, and then you see these big, like almost QRS complexes, no P's, very wide QRS. That tells you that the ventricles are very hypoxic, but they're still trying to do something. If you see the one below, that's just called idioventricular. It means the ventricles are firing, but it's kind of a last gasp effort. And this is very typical in patients that are passing away and they're on the monitor. Now, I'm including this slide in our presentation because at times we will run into some conflict during the decision-making process when people are terminal and there's some tough decisions that are being made by family, and we see sometimes family and providers and the healthcare team having some conflict. So this is actually one of our graduates from quite a while ago, but Dr. Nelson is an esteemed ethicist. So if you're ever looking for a good ethical theory regarding decision making, you can look up Dr. Nelson here. So this gives you some process to think of and to utilize if there are concerns. These are sometimes employed by the ethics committee at hospitals. So we won't really spend a lot of time on it. It's just that I wanted you to see if you have issues in the clinical area, there are theories and there are ways of thinking that kind of takes the emotion away from it. You can see this asks for options. What are some of the possible options that could happen in this situation, and then what's recommended? Why was it selected? Just make sure everyone is involved in the decision making, and specifically if we can get to what the patient wanted, that would be our ultimate. For patients that are on hospice, there's some great information from the Hospice Foundation. And if you're interested in this, again, there's good topics about myths about dying, signs of imminent death, which are the silver hour, how to comfort the patient, provide comfort, and then also how to help the family and us too with our grief afterward. As far as background, I think you've had hospice before, so here's a little bit about the criteria for hospice. And if you have a cancer patient, there is a Karnofsky scale that you can find, and it talks about with a cancer patient how I don't want to say sure, but I will say sure, how confident are we that 6 months is about what the patient has left, so we don't put someone in hospice too early. Hospice sometimes will, again, not give oxygen, not treat infections, so we have to be real careful with our patients going into hospice because they may not treat actively some of the concerns that show up. And finally, a question for you all to think about as you move forward. So really, how does your ethical practice and leadership thinking relate to not only end of life, but your entire practice? So you're going to be going out into the world soon, and just want you to make sure you are prepared as much as you can be for what awaits us, and do the best you can and take care of yourselves as well. This concludes all of our presentations and our content, so bring your good questions, and we'll have our final discussion shortly. So everyone, be careful, take care of yourselves, and we'll see you, and we'll discuss all this soon.